Hey everyone, it's Dr. Nurse Tutor. I am back with another tutoring session. This tutoring session is going to be different. It's not going to be an NCLEX tutoring session. This tutoring session is actually geared towards my master's level nurses who are preparing for their AANP certification exam. Like I said previously in my other videos, I have 15 years of experience as a registered nurse in bedside nursing, and I also have 6 years experience as a certified family nurse practitioner, along with a doctorate, a PhD in nursing education, and a postmaster's in online education that specializes in higher education. So I'm going to look into about 5 questions related to AANP certification style questions to help get you all prepared for taking this exam, or at least give you an idea of what some of these questions are going to be looking for so that you are prepared as to what is going to be presented to you. Now, the difference between this certification exam is, and I'm really just going to say it, and the reason why a lot of nurses, registered nurses, are failing the AANP certification exam is when you're going into this exam, you are forgetting to take your registered nurse hat off. When you become a family nurse practitioner or any kind of a practitioner, you become an advanced practice nurse. No one wants to know that you know how to hang an IV. No one wants to know that you know how to administer medication. No one wants to know that you know how to change a dressing. No one wants to know that you know how to read doctor's orders well. You are no longer a registered nurse when you come into the role of an advanced practice nurse. You are a provider. You are now working alongside and collaborating with physicians, with surgeons, with different doctors in different specialties, depending on the specialty that you go into. You have to take that registered nurse hat off and begin thinking and rationalizing like an advanced care provider. That's where everyone is messing up at. You are not administering medications based on the order of the physician. You are now the person who is going to be putting these orders into the computer, and the registered nurses are the ones who are now going to be following suit with the orders that you are putting in. So the questions that you are going to see are not going to be NCLEX-based questions in any sort, form, or fashion. So I'm going to present some questions here, a couple of questions here, so that we can go over and rationalize and think how I'm going to take care of this patient as the provider. What medications am I going to prescribe? What are side effects to these medications? What are off-brand medications that I can use to take care of certain patients? What are medications that I need to stay away from? How do I manage the treatment of these patients that I'm going to be taking care of? How am I going to take, and as a family nurse practitioner, you're going to have to understand you are providing care to everything from birth to death and dying. How are you going to manage the care of these different patients? You're not a pediatric nurse practitioner. You're not a mental health nurse practitioner. You're not a women's health nurse practitioner. As a family nurse practitioner, you are responsible for the care of everything from birth to death and dying. So actually, your specialty is pretty important and pretty, what's the word I want to use? It is pretty complex because you're responsible for taking care of everyone. It doesn't matter who comes through the door, you're responsible for taking care of them as a family nurse practitioner. So we're going to delve into some questions here so that I can break them down and rationalize and look into how maybe a nurse practitioner may think about it as opposed to how a registered nurse may think about it, and how to figure out how to answer and detect the correct right answer out of these questions. All right, so question number 1 says, given the laboratory results, which intervention is most appropriate? That's all that question says. Given the laboratory results, which intervention is most appropriate? So the only way to understand what this question is asking us is basically reading what the options from the answers are. So the first option says to inform the mother that her infant will need a HBV vaccination in 1 to 2 months. The second option is order the HBV vaccination for the infant within 24 hours of birth. The third option is order a hepatitis screening panel on the newborn. And the fourth option says to consult medicine for management of chronic hepatitis B. So HBV, if you don't know, please know that that is referring to hepatitis B. And that is a very important vaccination that babies usually need at the time of birth. And they actually have series of instances where they have to get up to 3 of these vaccinations. So HBV is a hepatitis B vaccination. So it looks like, given the laboratory results, which intervention would be most appropriate for a newborn baby? Most appropriate. So it's telling you that all of these answers are correct, most appropriate. Which one would you look into doing first? A woman looks like she just had a baby, because we're talking about the HBV vaccine for her baby. What would be the first thing that you would recommend to this woman who just had a baby? Would you inform the mother that her infant will need the vaccination in 1 to 2 months? Would you order the HBV vaccination for the infant within 24 hours of birth? Would you order a hepatitis screening panel on the newborn? Would you consult medicine for management of hepatitis B? So 2 of these options don't make any sense, right? So if it looks like someone just had a baby, do I need to do a hepatitis screening on a newborn baby who just came out of the womb? Would I need to be doing a hepatitis screening? In all actuality, if I needed to do a hepatitis screening on a newborn baby, and that's the third option that I'm reading from, if I needed to do a hepatitis screening from a newborn baby, that would mean that that baby's mother is positive for hepatitis B. Usually, we're not going to have a pregnant woman go through 9 months of pregnancy with hepatitis B and then give birth to a baby who will then have hepatitis B, because hepatitis B is actually transferred through blood. So nowhere in this question does it say that the woman has hepatitis B. So critically thinking, we shouldn't even be going in this direction, because we wouldn't need to order a hepatitis screening panel on the newborn, because the question doesn't even say that the mother has hepatitis B. So I would take that answer and just put that to the side. The next one, the last one, says consult medicine for management of chronic hepatitis B. Now, once again, doesn't say anything about anyone having hepatitis B, and it looks like the third and the fourth answers are pretty much saying the same thing, because the third answer is saying order a hepatitis screening panel on the newborn. Then the fourth one is saying consult medicine for management of chronic hepatitis B. How can this baby have chronic hepatitis B? Baby just came out. How can it be chronic? And it says nowhere that the mother has hepatitis B. So how are we treating hepatitis B or ordering a screening panel when nowhere does the question say that the mother has hepatitis B? Excuse me. Now the last 2, the first one says inform the mother that her infant will need an HBV vaccine in 1 to 2 months. Or it says order the HBV vaccination for the infant within 24 hours of birth. Now, the best right answer would be that the baby will need a hepatitis B vaccination within 24 hours of birth. If you don't know that, please write that down. All infants, if their parents are consenting to vaccinations, hepatitis B is usually given within 24 hours of birth. And then that second vaccine is usually given once that child has been DC'd from the hospital. The child now has a pediatrician, and then the child will get their next hepatitis vaccine within a month of getting the first hepatitis vaccine. So the last two options, it doesn't say anything in the question about the mother or the baby having hepatitis B. So ordering a panel and consulting medicine for management of chronic hepatitis B makes no sense. So the only other options would be either to get it within 24 hours or to get it 1 to 2 months after the baby's born. And you just have to know, please know that hepatitis B, you have to have that baby vaccinated within 24 hours of being born. And then after that baby has been discharged and goes to see the pediatrician, a month within seeing a pediatrician, they should have that second hepatitis B vaccine. Okay, so the next question is, prior to discussing a terminal illness with a Vietnamese patient, which should be determined first? So whenever you see that first or prioritize or best right answer, you usually need to know that all these answers are pretty much going to be correct. You just have to find the best right answer. What are you going to do first? So prior to discussing a terminal illness with a Vietnamese patient, which should be determined first? Now, the first option is the treatment plan. Second is religious preferences. Third is health information disclosure. Fourth is medical decision maker. So the patient has a terminal illness and they're Vietnamese. What are you going to discuss first? Let's start from the bottom. It says medical decision maker. Now, usually medical decision makers are used in a patient's medical treatment plan when either the patient is not of sound mind and body, meaning they're not alert and oriented ×3, and they can't make decisions for themselves. Usually those are the kind of patients who are elderly. Those patients are extremely confused, or the sickness has pretty much taken over their ability to make decisions for themselves. Nowhere in this question does it say it, but that doesn't mean that that's a bad option. So I'm going to look at the other options to see. The next one is health information disclosure. Health information disclosure basically means who in your family or who amongst your close friends or anybody around you that knows you are we allowed to give information about your health status to. Religious preferences just basically means what, based on your religion, what are certain practices that we can and cannot perform? Is there anything based on your religion that would hinder you from certain treatments? Like there are some religious practices, kind of like a Jehovah's Witness, who does not, they don't consent to blood. So there's certain preferences in people's religious backgrounds that you kind of have to pay close attention to make sure that you're respecting their beliefs and their practices. And then the last one is the treatment plan. Basically discussing what the patient's treatment plan is going to be and how you're going to help the patient with treatment for the terminal illness. So which one would we go with first? I'm going to go back down to the medical decision maker. A medical decision maker, kind of like a power of attorney, is the person that makes decisions for you when you can't make decisions for yourself. Nowhere in the question does it say that the patient can't make decisions for themselves. It just says that they have a terminal illness. It doesn't say that they're elderly, doesn't say that they're confused and they can't make decisions for themselves. So I'm going to take away that answer. Health information disclosure, I want to hold on to because it is important to know who you can and cannot give information to when it comes to the patient's illness. Religious preferences and treatment plan. Religious preferences, I don't think is more important than the treatment plan and health information disclosure. I don't think that I'm going to discuss your religion first as opposed to your treatment plan and your health information disclosure, and I'm going to explain why. Your treatment plan is what kind of medications you're going to need. The only way I can talk about your religious preferences is if I tell you what the treatment plan is going to be. So I would have to tell you what your treatment plan is going to be first in order for me to even know what your religion is for or against. So religious preferences wouldn't be discussed before the treatment plan. The treatment plan would be discussed before the religious preferences, because it won't matter what your religion is if you don't know what the treatment plan is, because that way, when I tell you what the treatment plan is, you can tell me, well, hey, in my religion, we're against doing X, Y, and Z. So treatment plan would come first before someone's religious preferences. Now we're left with treatment plan and health information disclosure. So though the treatment plan is important and you do need to discuss the patient's treatment plan, the most important thing as a provider before you discuss anything with a patient, their diagnosis, their medication treatment, what you need to do as far as their health care as their provider, the first thing a patient must do before starting care with that patient is health information disclosure. If anyone were to call here and want information about your treatment, or even if they were to call and say, hey, my spouse is a patient there and he got treatment from you all today, I need to know the status of what he was there for, can't give it to you. If that patient does not have you down as someone to give information to, you cannot disclose any information. That health information disclosure is usually filled out by the patient before you even see your patient. So you're not going to discuss the treatment plan, you're not going to discuss religious preferences, and you're not even going to discuss a medical decision maker until that patient fills out that health information disclosure, which is usually given to them in a packet before you even see that patient. So the very first thing you're going to do before even managing the care of that patient is the health information disclosure, because you have to tell me who I can give information to before I can even start your treatment plan. That's one of the most important things to do based off of HIPAA. You have to make sure that you know who can have that patient's information. This next question is kind of straightforward. It's something that you just pretty much have to know. And the question is, the patient's work history is a risk factor for which cancer? Now, what patient work history is a risk factor for cancer? The first option is esophageal cancer. The second option is glioma. The third option is mesothelioma. The fourth option is prostate cancer. So if I'm working at a job, from what we've seen on TV, anyone working at a job that is developing or has developed a cancer, what is a work-related cancer? Prostate cancer is usually a genetic thing. So I am going to say that prostate cancer can be thrown out because there's no evidence that really shows that a job will cause someone to have prostate cancer. Usually, like I said, it's highly genetic related, and we don't usually see patients come in or be evaluated for prostate cancer based off of their work environment. Mesothelioma, now if you have seen commercials with patients who have been in the work environment where they have inhaled things like asbestos in the work area, we know that asbestos is a particle that lives in the air. It is airborne. If you inhale it, it does run the risk of cancer. We do know that mesothelioma is a risk factor for cancer in the work environment. Then we have glioma, and glioma is not associated with an airborne type thing. So usually when you're looking at a work-related cancer, is something that's inhaled that would put the patient at a risk for developing a cancer, and glioma is not one of those. Now there is esophageal cancer, but esophageal cancer, like I said, it's not something that you're going to inhale that'll cause you to get cancer in the esophagus. So the biggest thing that you want to know that it is mesothelioma. Mesothelioma is associated with inhaling asbestos. And Or usually the work-related cancers is something that has been inhaled, and it's due to it being some sort of an airborne particle that the worker has inhaled over a significant amount of time that puts them at an increased risk of mesothelioma because of the asbestos-like material or particles that they have been inhaling for a significant amount of time while in the work area. So this one's a little straightforward. The mesothelioma has become pretty popular in cancers and issues that workers have had to endure due to the airborne particles that they are inhaling in the workplace environment. So that is something to know. If you don't know that mesothelioma is a cancer that is associated with, as a work-related cancer, and it's a cancer associated with asbestos and inhaling the airborne particles related to asbestos. Okay, so the next question is, which response would best address a patient's misunderstanding of addiction? Which response would best address a patient's misunderstanding of addiction? So that best is the word that you're looking for in the question, because that best means these answers are probably not incorrect. You just want to find the answer that would most fit a patient who had an issue with addiction. So the options are: explain that decreasing opioid dosing is now a state requirement. Explain that addiction is a complex disease similar to diabetes that involves multidisciplinary care. Ignore the patient's response, or describe the addictive nature of opioid pain medications. So there are 4 options here. From what it looks like, none of the options are incorrect. You just want to know what the best option for explaining opioid dependence or addiction to a patient's misunderstanding of what addiction is. So I'm going to start from the bottom, because I tend to like to start from the bottom just to omit as I work my way up. The first option says, describe the addictive nature of opioid pain medication. So the thing about pain medications and addiction, usually if a patient is already addicted to a pain medication, they understand the nature of their addiction. They're addicted to the medication, and they're coming to you for help based off the strength that they're already addicted to the medication. So explaining what the addictive nature of the opioid is to a patient who's already addicted to the medication, though it is something that you do have to do as a provider, that may not be the priority. As the provider, we do have to pretty much explain, what the medication is, how, though you do know that as a patient you are addicted and that is a medication that can be addictive, we do, as the provider, have to describe the addictive nature of the medication, but chances of the patient knowing that the medication is addictive and that they are addicted to the medication is pretty high. Patients who are addicted to the medications, when they're coming in for help, they already know that they're addicted. So explaining that they're addicted or the addictive nature of the medication probably wouldn't be a priority of mine. Ignoring the patient's response. Ignoring a patient's response to anything is ethically and morally wrong, so that would automatically be tossed out as an option, because you never want to ignore your patient's response to anything. Explain that addiction is a complex disease similar to diabetes that involves multidisciplinary care. I like that because you're thoroughly explaining what addiction is. You're comparing it to other diseases, so it's not a standalone issue. You're calling it a disease because it is a disease process, because we tend to stigmatize patients who are addicted to medications, but a lot of time addictions are not even their fault. And a patient may be placed on a pain medication after an acute injury where it may have been a surgery or a terrible accident, and this patient had to be placed on a narcotic for a significant amount of time. And now that patient has become dependent on the medication, which put them in an addictive nature. So we as the provider are now responsible for weaning that patient off of the medication. So explaining that it is a complex disease, that of other complex chronic diseases similar to diabetes is important. But I do want to see the other options so I can kind of compare the two. Explain that decreasing opioid dosing is now a state requirement. So when patients are placed on opioid medications, depending on the dosage, it is definitely a state requirement that we reduce opioid doses. So say you put a patient on a high dose of opioid medication for an acute situation, it is recommended that you don't just take the patient off the medication dry turkey. You do wean them off the medication by reducing the dosage over a certain period of time. So it is important that you do explain to the patient that though the dose that they're on right now, they may not be on it because later on during the treatment plan, because it is important that we do reduce the dose of the medications when we're going into the weaning process. But is that the most important? I don't think it's the most important, though it is something that we do have to discuss with the patient. I think the most important thing that you want to do is explain to your patient that addiction is a complex disease. It's a disease. Sometimes it's something that is not even their fault. It's something as a medication. Opioids are just medications that sometimes have to be prescribed to patients for a certain amount of time to help manage some nasty injuries that they have had that just cause them to have an addictive nature while being on the medication for a prolonged time. So explaining to your patient that this is a complex disease similar to other chronic diseases like diabetes, and it involves a multidisciplinary care team. You're going to have your primary care provider who's prescribing the medications to you, who is going to be watching you and managing your care for things like withdrawal, side effects, and adverse effects of medications. You're going to be tag teamed with psychiatrists, psychologists, behavioral therapists, family therapists. There's going to be a number of people that are going to be responsible for your care. So it is a multidisciplinary care team because it's a complex disease that requires multiple different entities of people involved in managing your care. So the best answer would be explain that addiction is a complex disease similar to diabetes that involves multiple disciplinary care. Multidisciplinary care. The other options, ignore the patient's response, is completely out of pocket. You don't want to do that. But describe the addictive nature and explaining that decreasing the dosage is a state requirement. They are important, but they're not the best. They wanted to know the best answer or the best choice answer that you would use, and that would be the second option. And now the last question is, the patient has a history of epilepsy and stable cardiovascular disease. Which 4 medications would be appropriate choices for this patient for smoking cessation? So you have a patient who is a smoker. Your patient is addicted to smoking. Your patient wants to stop smoking, but your patient has a history of epilepsy, seizures. Which 4 of these medications are appropriate to give a patient who has a stable cardiovascular history but has a history of epilepsy? So they are stable cardiovascular disease, which means whether it be high blood pressure or high cholesterol, whatever they have going on is under control with medication. So we know that they won't have any issues cardiovascular wise. But this patient does have a history of epilepsy, and it doesn't tell us that the epilepsy is stable, because usually when seizures come on, it is not something that you can pretty much determine. It's usually determined when there's an issue with the seizure threshold. Okay, so if the seizure threshold is reduced, then someone will have a seizure. So you kind of want to stay away from medications that would induce a patient to having a seizure. So let's look at the options. So the options are, which 4 medications would be appropriate to give a patient who has stable cardiovascular disease, but they do have a history of epilepsy. So the first one is nicotine lozenges. The second one is nicotine patches. The third one is bupropion. The last one is varenicline. I don't even know if I'm saying it correctly, but it's varenicline. I'm going to say it that way. So nicotine lozenges and nicotine patches, honestly, they're two in the same. It's just one is a patch and one is a lozenge. So when you see answers like this, it's the same medication, just taken in a different form. So chances are that's one of your two options. So I would not omit that, because they wouldn't say nicotine patch and then nicotine lozenge and one of them be wrong. So hold on to those two nicotines. So it looks like the option is either bupropion or the varenicline. So if we're looking at bupropion, both of these medications are actually safe to use for smoking cessation. One of these medications is not safe for a patient who has history of epilepsy. And the option, you just pretty much have to know this as a provider. So I would just write something like this down. Bupropion is the option, because though we do use it in practice for smoking cessation, bupropion is also known as Wellbutrin. It's a depression medication that can also be used as off-brand for smoking cessation. It does a pretty good job at not only helping with depression, but it does help with smoking cessation. The issue with Wellbutrin bupropion is that it reduces the seizure threshold, which is it's not okay to give to patients who are at risk for seizures or have had a history of seizures, because if you're reducing the seizure threshold, chances are you're putting your patient at a greater risk for having seizures. The varenicline is a medication that is safely used for patients who have safe cardiovascular stability and patients who have had seizures. There's no evidence that shows that this medication interferes with a patient who has epilepsy or cardiovascular issues. So it's saying that you want to, and I'm sorry, another option was nicotine replacement nasal spray, because they wanted you to choose 4 of them. So the varenicline, the nicotine patches, the nicotine lozenges, and the nicotine replacement nasal spray. All 3 of those options say nicotine. Nicotine replacement nasal spray, nicotine lozenges, nicotine patches. So they literally gave you the majority of the options. They wanted 4, 3 of them say nicotine. So obviously nicotine is going to be the answer. So you pretty much just have to decipher between bupropion and varenicline. Both of those medications tying my tongue, but it's just great to know, or it's good to know as a provider, because bupropion is also used for depression. It's an off-brand medication that is used for smoking cessation. So if you do get a question, they may try to flip the question on you and ask you, other than depression, what is bupropion used for? What is Wellbutrin used for? And if you see smoking cessation, please remember that, because the issue with being a provider is, though a lot of medications have first-line therapy, we do treat patients with medications that have off-brand success at treatment for other diseases. The same way how we would use Wellbutrin for depression, we can also use Wellbutrin for smoking cessation. But when you're going to do that, you have to know what the adverse effects or what the side effects of these medications are. And clearly, we learned today that if you don't know, Wellbutrin does decrease the seizure threshold. And if your patient has had a history of seizures, you need to make sure that you know that in their medical history, because that is not a medication that you can give that patient. So that was the only thing that we pretty much had to know the difference of, if you didn't know that about the medications. Okay, so it is the nicotine replacement nasal spray, the nicotine lozenges, the nicotine patches, and the varenicline medication that is safe to give a patient who has had seizures as well as cardiovascular disease, but they are stable. All right. Okay, so that concludes the questions from today. We pretty much spoke about patients' rights. So we spoke about opioid addiction. We spoke about prescribing medications, what medications to omit, what medications are first line, what medications are second line therapy. The biggest thing that I want you all to take away from studying for your AANP certification exam is, or whatever, I don't care if it's the FNP, if it's your psych certification, if your women's health certification, your geriatric certification, you are no longer a registered nurse. You are taking this exam as an advanced practice provider. Take that registered nurse hat off. You're looking at laboratory results to diagnose patients. You are prescribing medications. You are reading diagnostic exams. You are looking at history. You're looking at preventative care. You're looking at vaccinations. You're looking at everything that has to do with managing the care. You are not responsible for prescribing medications, for ordering tests and ordering labs to manage the care of your patient. You're going to be presented with questions that are going to give you a list of labs. They don't want to know that you know is high cholesterol. They're going to give you a list of labs and they're going to ask you to tell them what medication you're going to order based off of the results of the labs. So if your patient's labs show that they have high cholesterol, they don't want to know that you know that, because a registered nurse is supposed to know that. They're going to give you a list of labs and they're going to ask you to tell them, based off of the results, what kind of cholesterol medication are you going to order? Or they may not even say what kind of cholesterol are you going to order. They may give you a list of different medications and you're going to have to choose the cholesterol medication. But there's so many different kinds. So over the course of these questions that I'm going to be presenting to you, we're going to be looking at medications. What's first line therapy, what's second line therapy, what's third line therapy, because that's going to be very important to know. You may have a patient that comes in with an infection and they'll give you a list of different antibiotics and they want to know, what are you supposed to use first? They may give you amoxicillin, or they may give you clindamycin, they may give you azithromycin, and they want to know, as the provider, what are you ordering first? You have to know what the priority is before you even go to second or third line therapy. And even if, let's say, a medication first line therapy is in the penicillin family, right? Let's just say it's a penicillin or an amoxicillin and your patient has a penicillin allergy. Now they want to know, what medication are you going to order as second line therapy because your patient has an allergy to the medication that you would normally prescribe to them. These are some of the things that we're now going to have to start looking into as the provider to be able to manage the care. They don't want to know that you're a great registered nurse and you've been one for a while. They want to know that you now know how to manage the care of this patient as the provider, as the prescriber, as the specialist, as the collaborator. They want to know that you're going to be able to hold your own and stand on your own as a provider of this patient. So I hope you guys enjoyed these questions. I want to delve into, these questions are pretty much straightforward. In the next session, I want to delve into more critical thinking to pulling out the answer. A lot of times it's just going to be knowing what the medications are, or understanding what the lab results are, or understanding what the disease process is. We're going to get into a lot of disease processes also in these videos so that you understand how to, based off of the signs and symptoms that a patient presents with, what disease this patient may be coming in with, and how you're going to manage this care, and what medications and what treatment plan you're going to have for this patient. So be on the lookout for that, because these are the kind of questions that you guys are going to have, and we're going to have to break down to critically think to get the correct answer, because that is what these certification exams are going to be looking for. Okay, so if you guys like what you saw in my video, please don't forget to comment, like, and subscribe so that I can make more videos with this type of content. I'm going to have a couple of more AANP certification style questions for us to go over before I head on back over into my NCLEX question reviews for the NCLEX students that I have. So be on the lookout for a couple more AANP based certification questions that I'm going to be going over so that we can rationalize and critically think to get you guys passing these certification exams. Follow me on Instagram, follow me on TikTok. I am Dr. Nurse Tutor. If you would like or are interested in one-to-one tutoring sessions with me, please send me an email to drnursetutor@gmail.com. That is drnursetutor@gmail.com. If you're enjoying the videos, like I said before, please comment, like, and subscribe, and I will have more videos coming your way. But for now, I'm going to end here and be on the lookout for more videos throughout the week. Bye-bye.